to do that? Okay, so and welcome everybody, and I'm just wanting to repeat that we're excited to introduce Dr. Robert Lindsay to the group tonight. He generously offered to speak with all of us, and he is a chief of endocrinologist at Helen Hayes Institute and Hospital in New York, and West Haverstraw, New York. Haverstraw, New York. And we're thrilled to have him. He comes with many accolades in terms of his research in osteoporosis, and he generously offered to not only speak with us, but bravely to answer our questions concerning standard of care and that we have received, and questions that we may have addressing those issues. So anyway, without me saying another word, I'm going to present to you Dr. Lindsay, and thank you for coming on here, Doctor.
Thank you very much for inviting me, Shelley. I really appreciate it. And of course, you have just discovered the reason that I'm interested in this disease. It's the only chance I get to speak to a whole group of young ladies. Otherwise, I'm on my own. But I'm going to start with talking a little bit about what I see some of the problems that we face today. And they're more related to the practice of medicine in a way, rather than they're really related to osteoporosis. But osteoporosis gets right in the middle of it. And this is a long-standing story in a way. Several years ago, a colleague and I got invited to talk to physicians who were working for insurance companies. They had a United States meeting. They happened to have it in New York, and I wasn't going to travel very far, so I just drove down and I spoke to them. And I realized that as I walked into the room, the problem was I was going to talk about osteoporosis, and never a single person in that room was male. And so I decided to do it in a little bit of an odd way. I said, you guys are responsible for a lot of the things that we do. You pay for the medicines, you pay for the tests, and you often question whether or not we're going to use the test. I'm going to ask you a question. You are now seeing a physician for the first time, and the physician tells you that you have a chronic disease which is going to have to be treated over a long period of time. And you say, oh, okay. And you talk a little bit about the treatment, and you say to the group, the medicines that we use have effects, and the effects are measurable. But according to the criteria that are laid down for the management of this disease, the test that gets spoken about most, I can only do once every 2 years. So I'd like to ask this group of male physicians working for insurance companies, how many of you at the end of 2 years are going to be on the medicine that I have suggested you be on, not knowing whether it's working or not? And they were all fairly honest. They all shook their head and said, no way, no way, no way. And I said, okay, what are the regulations that you've put in place for bone density measurements? Once every 2 years. I said, yes, and there are times where that's appropriate, where it's used that way. There's nothing wrong with it. But I use it in the following way. At least one of the things I use in the following way. I want to be able to tell the person that I'm treating that the medicine that I am giving out is having some sort of beneficial effect. Because in reality, all medicines have side effects, and side effects often take priority from the patient's point of view. And now you're telling me that this test that I want to use, called bone densitometry, I can only do once every 2 years. So how many of my patients at the end of 2 years are still going to be on the medicine? Most of them have all given up the medicine, and most of them have given up me for making that stupid suggestion that they be on a medicine for 2 years. And they sort of mumbled among themselves, and then they said, yeah, we have to think about that when we go back. I said, okay, well, there is an alternative, you know. They looked at me like I was totally crazy. And I said, we have methods of measuring the metabolism of the bone. And we can do that based on blood tests. And mostly people insurance companies will just pay for it. It's another test. It's $100 or so. They just pay for it. But every now and again, I get a letter from the insurance company telling me that they're not going to pay for this test because it's not approved for clinical use. And at that point, I go, okay, what year are we in now? Let's say 2020. Okay, we're in 2020. The test that I want to use was approved by the Food and Drug Administration in 2002. And you've been paying for it on and off. And this obviously is one of the off times. Now, why are you doing that? And they said, well, you know, what happens is these tests come in, and if they're not used very commonly, somebody gets to look at it and decide whether or not it's something we're going to pay for. I said, and there's somebody who makes that decision today and says you're going to pay for it, it's going to be different than the person who makes the decision tomorrow because they've got a different piece of paper, different information, or what? And there was silence. They have no idea why that was happening. And I had two bits of paper brought along for the occasion. I had one in one hand, one in the other hand, and I said, this lady has her biochemical evaluation paid for by you. This lady has her biochemical evaluation paid for by you. But this lady gets her bone test, this lady does not. Can you explain to me why that happened within a month? Patients in good standing, same insurance company, same insurance plan that we're on. And they said, oh no, but that shouldn't have happened. And I said, yes, you're right, it shouldn't have happened. Especially since here is the publication that the FDA put out in 2002 that said that this was a good test. And it was a good test for trying to identify people who were losing bone. And it's a great test for trying to quickly evaluate whether or not the medicine that we're using is doing something great. I can do two blood tests, one before a patient starts on it. I get the measurement that we use is called CTX, or acetylpeptide, which is a measure of little bits of collagen that come out of bone when the cells are removing bone. Those get into the bloodstream, and that's the test that measures them. For the patient I'm seeing for the first time, and I'm worried about the fact that they might be losing bone, when I do that blood test, if the blood test is high, and that suggests maybe there's a lot of bits of collagen coming out of bone, and maybe I ought to pay attention. Doesn't mean I want to treat them necessarily. It just says I have a warning note that they may be losing bone. And then I have a different patient comes in after that, and this is somebody that I have put on, let's say, a bisphosphonate, alendronate for the want of a better one. And I put them on alendronate, and before I put them on, I do the measurement of that test. And then 1 month after starting alendronate, I do the same measurement again. And the test will have gone from here down to here. And it shows me that they're getting an effect because alendronate has turned off the mechanism that we use to lose bone. It stopped the cells from removing bone. And I can say to the patient, the medicine is working, keep taking it, and we'll measure your bone density, but I'm not going to wait 2 years. We're going to do it in 1 year. And I get a phone call a week later from the patient that says, my insurance plan says it's only going to do bone density every 2 years. I said, you tell your insurance plan to call me or talk to me in some way. Oh no, they want you to call them so you can have a peer-to-peer discussion. I said, I'm very happy to have a peer-to-peer discussion, but I don't know any of my peers in bone disease who are working for insurance companies. They're probably much better than I am in general medicine, much better in other areas of medicine, but they don't know very much about bone. And it's a little disturbing because we actually knew about the fractures related to osteoporosis several hundred years ago. There were people who studied hip fracture in the population. And they said, you know, there's something funny going on because people get hip fractures when they get older. And the older they are, the greater the risk of getting a hip fracture. And we don't know why that happens. Maybe it happens because they're not as strong. Maybe they fall more frequently. Maybe there's something else going on that we don't know about. But certainly that fracture occurs in aging individuals, in older individuals. Then along came the 1930s. In the 1930s, a physician called Fuller Albright was able to decipher that women lost bone after they went through menopause. And that was considered to be something that we didn't talk about very much because we didn't really talk about ovarian function in those days. But when ovarian function went away, you could see the bone density going down. And we have methods of measuring bone density. We use hand x-rays or so on. But you could see the bone density going down in individual patients. And Albright was the person who said, you know, this disease occurs in women primarily because women go through a menopause. If men went through a menopause, they'd get this disease too, but they don't. They have much slower, gradually declining endocrine function of the adrenal and the testes. But women's ovaries stop working. And he showed, furthermore, that there was good evidence in a clinical trial done in the late 1930s that giving back hormones to patients reduced the rate of bone loss and protected them from bone loss and protected them from osteoporosis. About 20 years later, his patients were re-evaluated by another couple of physicians who said, you know, the frequency of fractures in that population they treated is very low. And that got us to a point where we now knew why. We knew that women lost bone because they lost ovarian function. And we knew that replacement of ovarian function resulted in reduced rate of bone loss. Then all hell broke loose. It broke loose because of a study that was actually a very big study and unfortunately used in a way that is a little regretful. It's called the Women's Health Initiative. It was first published in 2001, and it was an attempt to see if estrogens had multiple effects in women after the menopause. And the first thing they came out with was, oh, estrogens cause breast cancer. And the utility of estrogen went down hugely. And then it was estrogens don't protect the heart. Oh, went down even further. And then most recently, a statement is made that estrogens might actually be important in Alzheimer's disease or dementia. And now almost estrogen therapy almost completely disappeared. Well, they were part right, because mostly those negative effects were related to the progestin that was used in combination with the estrogen, the progestin being there to protect the lining of the uterus from becoming malignant. Then we got into medications for it. And medications, we have about 11 or 12 of them. They're actually pretty good. But they address the bone issue. I remember way back 10 seconds ago when I was talking about the older data, I said they couldn't figure out if women's bones were changing or they were increasing the risk of a fracture because they were becoming less mobile to fall. Well, both of those are important. And we really have not stressed that feature to as adequately as we should. There's a wonderful paper that came out 2 weeks ago, just to show you that I do read the news every now and again. This is a lovely medical paper that is really an epidemiological evaluation of exercise as we get older. And it looks at current exercises and it looks at what people did in the past. And what it says is the idea that as we get older, we should slow down, not do as much as before. Maybe not run the marathon, maybe just trot for 10 yards or so. And that's not the way that we really, when we look into generations in the past, that we really aged. We aged because women were relatively immobile during their formative years or during their young adult years because most of the populations then were essentially hunter-gatherers, and they were on the move all the time. And in order to get pregnant, you can't be on the move all the time. And so these populations had a relatively slow rate of maneuvering or exercising until ovarian function started to go down. And then women said, hey, yeah, I don't have to worry about getting pregnant anymore. I'm going to go. And the model that they used for that, believe it or not, was the great apes. Because the great apes are fertile, and when their ovarian function stops, they just sit down and they die. Women don't die. But the concept is that they could live a better life if they adopted the idea that being physically active is probably more important than any other thing that you do. And it's good for bone. We forget that. I get asked all the time, what's the best exercise for osteoporosis? There's a very simple answer to that. The one that you're prepared to do. I can tell you what to do, but if you're not going to do it, it's not going to work. And then people will say, well, what about walking? And walking is great, but walk briskly. Walk as though you mean it. Because every time you do that, when your heel hits the ground, your bone is getting a little impetus. And that's going to help keep it strong. Your muscles will be strong because you're exercising. You'll be less likely to fall. And that will give us a greater reduction in the rate of osteoporosis than we see now. Because even before the last couple of years, the frequency with which doctors were prescribing medicines for osteoporosis was declining in the United States. And a lot of that is based on what we might call popular media. And for me, the whole YouTube grow up and so on and so forth really is something I don't understand very well. I'm the sort of person who thinks that, oh, look, here is a really good little device. And if I use it properly, I can make words with it, even sentences with it. That shows you how backward I am. But we forget about the fact that simple things really matter. And if I had one thing to ask all of you, it is as you go through menopause, as you get older, don't ease up. Do whatever you can. Now, of course, people are going to say, well, I've now got arthritis in my knees or my ankles or my hips. Yeah. Mobility is important for arthritis as well, but you choose the mobility to suit what the problem is. And that's, of course, why we have wonderful physical therapists who will tell you what to do. The other thing I say to people is, okay, you live in a house. Is your house on one level or two levels? If it's on one level, I don't know what to say. But if it's in two levels, I tell them, spend your day going up and down stairs. Great for your bones, great for your muscles. And believe it or not, psychologically, you'll feel better. Because you'll have been exercising, even if you didn't leave the house. It's going to snow up here, and I guess up with you guys tomorrow. Not going to be too many people outside doing exercise, but you can do it inside. You don't have to need anything fancy. But part of the problem that we face in talking about osteoporosis isn't just the medicines. Part of the problem is the plethora of pseudo publications that come out every day on YouTube and on other websites that say, take this, it's something that's missing, and if you take it back, your bones will be better. Not it's preventing osteoporosis, just your bones will be better. And every single one of those things has absolutely no significant data to support that statement, but they're allowed to make it because they're not making a statement that they treat or prevent a disease. They're just making the bones better. When Shelley asked me to come and talk, believe it or not, that night I got an email, one of those things that flutters around all over the place, for something like that. It said, throughout life, you need this vital agent And if you're not getting it, your life's going to be terrible. Your muscles will be poor. Your brain will stop working. Your bones will start deteriorating. And it'll be terrible for you. Why don't you take this every day? I looked at it and I went, is it? It was for collagen. The collagen is important. It's the main ingredient of the of bone. But taking collagen by mouth doesn't mean that you're giving collagen to bone. What you're doing is you're taking in the amino acids that the collagen has, and you're giving the amino acids to your body to then help turn into bone or to turn into muscle or to do other things, cardiac function, for example. But it has to be because the collagen itself breaks down in your stomach and you absorb the amino acids. And nobody ever figured out how to get those amino acids all back together again to give you collagen. But those amino acids are important for the collagen synthesis in the body overall. So getting a reasonable amount of collagen is not a good thing. But it's not going to prevent osteoporosis because it's not going to deal with the primary problem, which is the loss of ovarian function in women. Now, what do? Well, you've heard half of it already. I am very anti-medication. I am a very old guy and I take no medication. And the reason I take no medication is that every time somebody would try and stat me on something for my blood pressure or for my cholesterol, I'd feel miserable. Statins gave me terrible muscle aches and pains, and no matter which statin they tried, it just didn't get any better. So I said, I'm going to stop this. I don't really need this. I stopped the medicines, and here I am at about 188 and still talking. But you know what I'm doing? I'm exercising. Not running the marathon. I can't do that anymore. My joints would give out. But I do exercise of one sort or another every day. My daughter is a competitive rower, rowed in college and rowed subsequently for the United States. And she donated to me what the rowers call an erg. It's a rowing machine. The rowing machine sits in my basement, and whenever I go down to the basement, I think, oh, I've got to use that for a few minutes. And I get my exercise. I don't have to do anything special about it. If the erg wasn't there, I'd probably just go out and have a walk until tomorrow when it snows. The erg is in the basement. I can sit down, I can exercise at any point. And we have to make physical activity critical in our lives. If we don't do that, it's all going to fall apart because the medicines will help you maintain your bone, and some of them will help you rebuild the bone, but they won't do anything about your risk of falling. That part is on you. And that's where exercise comes in. It's very clear that people who exercise are much less likely to fall than people who think that getting up off the couch is exercise. And I see a lot of those people. And when they come back and I ask them if they're exercising, they say, yeah, I got off the couch twice yesterday. It's just not a thing that we have taken as a priority. And we should have known about that because in younger individuals, premenopausal women, exercise is important too. But if you exercise too much as a young individual, you cause loss of ovarian function. And when that happens, bone loss occurs. You're not at any risk of falling because you're physically very active, but you still get bone loss because the ovaries have stopped working. And you know where we showed that? Believe it or not, in the West Point cadets. Because we were able to get access to the young ladies there, aged between 18 and about 24. And we measured their bone density and we followed them through time. And the ones who were amenorrheic during that period of time, exercise-induced amenorrhea, they got some bone loss. It wasn't a huge deal, but it was there. And that sort of said, well, loss of ovarian function at any time is bad. So then we get to men. Men gradually lose their hormones as well, but it's more gradual. It's over a 10-year period. And that's why we don't see bone loss in men, because as the hormone levels are gradually going down, as long as they're above a baseline point, bone density doesn't change very much. And so men lose bone after they're 60. Women lose bone somewhere in the region of 45 to 55 or 60. Sorry, somebody keeps coming in. And he shuts off Shelley's face, and I can't have that done. So I have to do that. But treating osteoporosis, or diagnosing or treating osteoporosis, is actually not that much different than diagnosing hypertension or hypercholesterolemia. You go into the doctor draws a blood sample, and 2 weeks later says your cholesterol's high, you're going to have to take some medicine. Well, maybe. If you don't take medicine, there are other things you can do. And believe it or not, for cholesterol, exercise is important. For blood pressure, exercise is important. And we're unfortunately in an age where exercise is almost a 4-letter word for some people. I keep talking about it and talking about it and talking about it. Why? Because it's the one easy thing to do that will have beneficial effects on everywhere in your body. Have you ever watched the people finishing a marathon? They are almost collapsed out, and then 30 seconds later, they're jumping around and they're cheerful and they feel really good because they've done something wonderful. You get the same if you go for a walk around the schoolyard. It's important to exercise. Now, the medicines that we have are problematic because they all have side effects. And that's one of the biggest problems in any form of medication. All medicines, as far as I'm concerned, have side effects. But they're important because they will reduce the rate of loss of bone, or they will help rebuild the bone. The problem is the ones that rebuild the bone are more expensive than the ones that will retain bone. And so, going back to my least favorite topic, insurance companies, they want the patient to be on the least expensive one. And they don't really care what the metabolic status is or how we've worked the patient up or what we think the issue is. No. You don't want that. You don't want the medicine that you have to inject every day and cost them several $1,000s a month. They want the medicine that you'll take as a pill and cost them $100 a month. And you can understand why they would want to do that. But it's interference in the practice of medicine. And if I had one thing that I could change, it would be allowing insurance companies into medical practice. For example, they will say, this clinical trial showed that we can prevent bone loss. About 30 years ago, one of my colleagues in Omaha, Nebraska, called Bob Heaney, who was really a giant in this field, and he did a little study. He looked at the last clinical trial that had come in, looking at a medicine for osteoporosis in women. And then he took that and he compared it to the population of women that he was seeing. So over a year, he looked at every new patient that he was seeing. And by the end of the year, he said, people are going to use this clinical trial as a generalization. Everybody should get this medicine. He said, 75% of the people I saw would never get into that clinical trial. Because clinical trials are usually done to show the medicine works. And that means that the criteria for getting into the clinical trial are as focused as the company can make them, as the FDA will allow them to make them. But most of the people that we see would never get into that little group. Why? Well, co-medications are bad. Other diseases are bad. If you are wheelchair bound, for example, you'll never get into any of those clinical trials. And so when we look at it, we're using a study in people that we don't normally see to make decisions about the people that we see who wouldn't normally fit into that clinical trial. And that's really hard. And it's very difficult to say to somebody when they say, is this medicine going to work? And you go, well, if your insurance company allows me to do that blood test, we'll be able to tell you pretty quickly how it's working. And we'll give an idea of whether or not you're going to really look like the active wing of that clinical trial and have a reduced risk of a fracture and have a better life as a consequence. Because as physician whose name I can't remember now, and I apologize for that, said very recently, if you're dealing with children, then the important thing is to determine the length of their life and to try and improve that. But if you're dealing with people over the age of, let's say, 50, what you want to do is make their life better, because anything you do is not going to have a huge effect on their longevity. But it's going to, if you can make their life better and they're going to have a good time, they should thank you for that. And that's mostly what we're trying to do. I've talked for long enough. I'd like to stop there if I may. And I'm happy to answer any questions that anybody has. We'll give it back to Shelley as the moderator.
Well, that was great. You know, I do think you had questions, so I want to address those first. So I'm going to read from the chat on the side. And the first one was from Steffi, who says, does every exercise have to be weight bearing? Or is it that where rowing comes in? Can you recommend how much weight bearing exercise we would need?
Well, the how much is a real big problem, because that depends on each individual and what they're prepared to do. But exercise on dry land is weight bearing, one way or the other. The only exercise that's really non-weight bearing is swimming. And swimming doesn't do anything for bone. It's a great cardiovascular exercise, thoroughly recommend it, but it wouldn't be the choice of anything for bone. For bone, go out and have a walk. If you like to walk. Oh, I don't really walk very much. It takes a long time. Okay, shorten it and go for a run. But do something that allows you to go do this with yourself on the ground. That's you weight bearing. And you're giving a stimulus to the bone, and the bone will respond to that stimulus.
Excellent. Okay, thank you. And then you've got another question. We've noticed in our group, actually, that many of us have been avid exercisers our entire life. We've discussed this at length. So many of us have the problem that we have done good nutrition. We've done all the things that you can change for your lifestyle that will improve your bone density, and that hasn't been, we've still come up short. Specifically, this particular question is about exercisers. You know, are you saying that you don't recommend medicine at all? Or are you saying that if you were on medicine, like a little unclear, because we've tried out a lot of lifestyle changes. Yep. We've already been doing that. What then?
No, I'm not disputing the need for medication. There is a need for medication, and it can be used hopefully wisely. But what I'm concerned about is, for example, somebody getting a bone density at the age of, let's say, 50. And the bone density comes back with a statement that says, this lady has osteopenia and needs treatment. The next thing you know, this lady is getting medication. And that is one of the big holes in this field, because osteopenia was a term that we originally borrowed from radiologists who, when they looked at x-rays, it looked a bit washed out. They needed a term for it, and they weren't allowed to make the diagnosis of osteoporosis. So they developed this word osteopenia, which, if my classical languages are correct, means too few bones. Doesn't mean less bone. But it refers to people who they think might be at risk of getting osteoporosis. The people who are in the lower part of the normal range. And then it says, classifies them all together. So my 50-year-old woman gets her bone density and is told that she has osteopenia. If she is 5 foot and 100 pounds, that's where she ought to be. Because when she grew up, she developed the skeleton that she needed for the body size that she has. If she were a footballer for, I guess I should say, the New York Giants, and had bone density in the same range, I'd be really worried for two reasons. Firstly, that person has no right having a bone density down there. They've got a bigger skeleton and their bone density should be in the top part of the normal range. But now it's down there. And then the next thing is stop playing football because you're going to get killed. But the key is then, having got a bone density, recognizing that different people get different diagnoses based on that bone density. And there's nothing wrong with having, as you know, we use a statistical range for normal, where the average value is set at 0, the top of the range is plus 2.5, and the bottom of the range is minus 2.5. And if you fall below minus 1 to minus 2.5, you get this definition of osteopenia put to you. I'll go back to what I said at the beginning of this. If you're 5 foot and 100 pounds, that's where your bone density should be. And if the patient is then worried about it, then we use the biochemistry to figure out if bone loss is ongoing. And if it is, then we get involved in intervention. An intervention can vary from estrogen treatment, which is still used by some people, to estrogen receptor agonists like the raloxifene, to bisphosphonates, to agents that rebuild bone like the parathyroid hormone molecules, Forteo and Tymlos, and teriparatide now, which is a generic form of it. So the medicines are there, but the first thing is to make sure that the patient is going to need it, because they're going to be on it, certainly for the agents that prevent bone loss. They're going to be on that medicine for a while. Some people will be on it lifelong. And then we get into what are the lifelong side effects of some of those medicines, and they're not good. But fortunately, they're not that frequent. And we have mechanisms of trying to figure out if somebody's at risk of a side effect.
Oh, you do?
Sorry?
I wasn't aware of that, to know how you know if someone will have a side effect.
Well, the two side effects that we talk about all the time for the anti-resorptive agents like the bisphosphonates or denosumab, Prolia, are osteonecrosis of the jaw and an increase in the risk of breaking the shaft of the femur, the thigh bone. Right. Osteonecrosis of the jaw really was originally found in people with cancer who were getting high doses of those drugs, mostly the one that's now reclassed. It was called zoledronic acid in those days, and it was given in high doses to prevent the cancer spreading to bone. But these people got osteonecrosis of the jaw because they had terrible mouths, horrible. They had cancer. And keeping their mouth good, clean, and in workable order wasn't high in their priority. And osteonecrosis of dead bone in the mouth happened when they got invasive dental work. And that's the key for that one. And if you have someone on a medicine and they need dental work that's essentially like getting an implant, then they are at risk of getting this problem and they need to be told about that. The dentist will tell them. The most likely response from the dentist is, oh, you're on one of those medicines, are you? Well, the guy down the road is very good. He knows all about this. Why don't you go see him? They don't want to deal with it because they can't decide whether somebody is going to get the side effect or not. The other side effect, the fractures in the thigh or the femur, that got a lot of publication because it's sort of bizarre, because the femur, the thigh bone, is the strongest bone in the body, but we don't break it. Really, the only people not on medicine who break that bone are downhill skiers, who, if they tumble and the skis don't separate from their boots, they can get their legs so mangled up that they break the femur. The rest of us, no. But when you look at autopsy data, you discover that the femur has cracks on it that appear every so often and presumably heal because the bone doesn't break. But those medicines are designed to reduce the metabolism of the bone. And so the argument is that maybe one of those cracks doesn't heal as quickly as it needs to, and it propagates across the bone and breaks it. And that's what the X-ray of the break looks like. It looks like somebody just went across the bone and took it out. You get some warning of that because the warning is pain in the thigh. And we tell everybody on any of those anti-resorptive medicines, if you develop a pain in the thigh and you have it a week later still, you call us. And we figure out it was a problem. And we think we can reverse it. The unfortunate thing is we don't see enough people at that stage. People still break their bones, end up getting surgical intervention, and then getting into rehab, and it's just like having a terrible hip fracture. So the side effects are concerning, and people need to pay attention to them.
Thank you. I'm going to open it up to everybody to be able to just talk. Why don't you unmute if you'd like to ask a question? Let's keep it going for a bit. I see, there's a couple more questions that you've gotten on the side here. Let's see. Tish said, this clinical trial question you had, was that in terms of drug companies that are running those clinical trials? Is that what you meant by that? That they were choosing people based on the success of the trial?
Well, they're using people with the problem, either because they've got low bone density or they've had a fracture in the past. That's the starting point. But then they eliminate people who have problems that might make it difficult for them to either to participate in the study or to return to get their bone density done, or don't have a life expectancy. That's the duration of the study. And then we get into, what do you do with somebody who's got multiple sclerosis? What do you do with somebody who is in a wheelchair, was the one I raised? And what are we going to do with people who are astronauts? Astronauts lose bone because they're out of gravity. And they're already doing studies of anti-osteoporosis medicine in people going to the space station. So it's all really a question of realizing that when we're trying to prevent osteoporosis, we're dealing with a patient, a person, and you have to look at the person from all angles before you ever decide whether or not medication is going to be more useful or more dangerous.
Okay.